Hello, my name is Jacob Nacht. I'm an emergency physician at Denver Health and the medical director for the Denver Paramedics. And I am going to be talking to you about explosives and incendiary devices today as part of a just-in-time training series. These are the standard disclosures for the funding source of the grant. I'm not going to read through them. I have no financial interest or conflicts of interest or relationships to disclose here. The agenda. So as I mentioned, I'm an emergency physician and work in EMS, and I'm going to kind of come to it from mostly a clinical side. We're going to review some of the common incendiary and explosive agents and then discuss the clinical implications. We're going to look at dynamics of explosive forces, reviewing some injuries associated with these devices, including the pathophysiology and the management. So as an introduction, why is this an important topic? Explosions and incendiary devices are a common cause of morbidity and mortality, depending on the environment that one is in, both intentional as well as accidental. A couple things that make these sort of incidents a little more challenging. Many patients will self-present. These are not all large-scale multi-patient events. Almost guaranteed things will start to unfold prior to a complete understanding of what actually happened, whether it's 911 calls or patients presenting to the emergency department or to medical care. There's a wide-ranging source of injuries and source of these events, from military, fireworks, industrial, residential, tires exploding. So it really does, I think a lot of us probably think a little bit more of these type of terrorist events, but it is important to just step back and realize that these can happen. Unfortunately, many of these are terrorist events. We have numerous examples in the last handful of years that cause very significant damage, morbidity, mortality, and are a major concern for those not only planning events, but just running kind of day-to-day operations for cities and institutions. So getting into the material a little bit, just some definitions. So incendiary versus explosive. So incendiary are it's a flammable substance. It's designed to start fires, whereas explosives can be any number of forms, liquid, powder, solid, material, but this is designed to lead to a sudden release of energy. With all of these events, it's really critical to first just consider doing your best to figure out what the substance is, but the consideration for decontamination. All of these events have the potential for chemical, radiological contamination, and while we want to start caring for patients, the last thing we want to do is start adding more patients by contaminating either providers, ambulances, emergency department, etc. So I will touch back on this at the end, but this is just something that should be in the back of all of our minds. So starting with incendiaries, some common incendiary substances include magnesium, which can be either a powder or a solid. It reacts with water and releases hydrogen. As such, can cause inhalation burns, and critical with this is to remove the particulate before irrigation. This is part of the decon process and also underscores how important it is to try and get a sense of what the substance is. Makes sense if you have a powder and you start irrigating that it's going to cause further issues with this reaction. White phosphorus is typically a solid, ignites when exposed to the air. With these patients, you tend to immerse them in water or saline. It is lipid soluble. Thermite is a metal powder and is often sort of challenging to ignite, but that's why magnesium is often added. And If there is sort of a fire or sort of an explosion, it can scatter this molten iron because there is metal components. With these patients, we cool and remove contaminated debris. The biggest commonality, and there's going to be other substances that can be used in these incendiary processes, but that they're all highly flammable. They all generate extremely high temperatures, and they produce burn injuries. I'm not going to get into burn classification too much. This image really shows the old nomenclature of first, second, third degree burn. The newest language is really superficial, partial thickness, and full thickness. Burn management for patients exposed to an incendiary process is really fairly standard burn care. Stop the burning process, airway, breathing, circulation. As is always taught, any airway involvement, it's important to consider early intubation, as the swelling and damage to the airway can progress quickly. Volume resuscitation is critical with so much damage to the skin. There's a number of different ways to do this, whether Parkland, urine output, rule of tens, and probably most importantly, these patients need to be transported to a burn-capable center, and trauma will always trump burn in the treatment of patients. So moving on to explosives, as I mentioned, an explosion is a sudden release of energy causing a pressure, basically a pressure wave. And as that force expands out, it can be a chemical reaction that converts a solid or a liquid material rapidly to a gas. And this release of high temperature and pressure is kind of what causes that wave that goes out. There are a number of different substances that can be involved in the explosion. Just mechanical, chemical. Mechanical would be like a tire or something air-filled exploding. Chemical might be a mixture of things, nuclear, or it could be a combination of all of these. When we talk about explosives, there are two main categories. High order, which we'll talk about a little bit later, actually causes a blast wave, which is different than just the wind that comes off of many large explosions. Some examples of this: dynamite, relatively easy to get, but does degrade and doesn't store well. Ammonium nitrate is a readily available substance. ANFO, C4, TNT, these are all sort of high order and can be used in isolation or in combination. And then there are low order substances, gunpowder, petroleum-based, kind of smaller pipe bombs. It's important to remember that many, you can have explosive devices that are military, I guess more organized, or more specifically, kind of in an institution, or you can have these improvised devices. So pipe bombs, a vehicle-based bomb with chemicals in it, bombs in a backpack. And part of what's so challenging about this is that they can be hidden, they're more transportable. They are also probably a little more volatile because they're often just sort of homemade. They can have remote detonation, as showed here, with the phones, with the radio. Many of these devices, there are instructions on how to build them online. And it's part of what makes them so insidious, is somebody can go do some education and learn about this, and then put one of these together. One of the important things to remember with improvised devices, but with all explosives, many times where there's one bomb, there are others, and often these attacks will be orchestrated to target first responders after an initial device goes off. So, as I alluded to a little bit earlier, this concept of a blast wave that is unique to a high order explosive. Some of you may have seen videos where you can see an explosion, you can hear the explosion, and then in a slight delayed sense from that, there's actually a sort of a wave or an impact from this blast wave, that there's such a rapid expansion of gas from the explosion that creates a negative pressure and then an outgoing wave. This is unique to the high order, as I said, is different than the blast wind, which is just from potentially low order explosives. Some of the characteristics that change the impact of an explosion include whether it's enclosed or open, in a building, something like that. What else was involved with it? Sometimes these improvised devices, as shown in the picture, will have shrapnel that's associated with them, designed to inflict more damage. Any kind of reflective items, walls, things like that. And then, of course, distance, and whether this was something underwater or traveling through the air or in the ground. So we're going to move on a little bit to injuries. So injuries with explosions are categorized into these four sort of categories. And I'm going to sort of walk through as this chart shows. So primary injuries are unique to high order explosives because they're the result of this overpressurization blast wave. The structures that are most susceptible are gas filled. So lungs, GI system, middle ear. Types of injuries include blast lung, pulmonary barotrauma, which we'll talk about a little bit more, and tympanic membrane injury. You can also have abdominal injury, globe injury, and potentially head injury. Secondary is caused by flying debris and fragments. So this can happen with any large explosion, whether these were designed shrapnel that were part of the bomb, or whether this blows up a car and pieces of the car fly. This can damage any body part, and is sort of penetrating trauma, but is often from just either small things like bolts and screws, or large chunks of metal. Tertiary is caused by individuals who are actually thrown by the blast wind that comes off of the explosion, cause a number of traumatic injuries. And then quaternary is sort of everything else that is explosion-related illness, not due to the first three. Can be any body part. This includes burns, contamination, traumatic brain injury, which is as we know, is a huge cause of morbidity and mortality in the military as well as other fields. And then sort of toxicological stuff, CO, cyanide. So with these blast injuries, it doesn't take a ton of force really to cause injury. 2 to 5 psi can cause tympanic membrane rupture. 15 psi is what it takes to cause lung injury. And then 30 to 40 psi, which in some ways is you think of as not being that much pressure, about what you're putting into a bike tire, but if that's coming out, can actually be lethal. These blast winds can have very high winds that can cause significant damage. Getting to a couple of specific injuries, blast lung significantly varies in terms of incidence, can be quite delayed, up to 48 hours in terms of the impact. Basically destroys the alveolar wall and causes edema and hemorrhage, and really just destroys the parenchyma and the tissue of the lung. You can see pneumothorax, pulmonary contusions. This will often present with dyspnea, hypoxemia, tachycardia, tachypnea, hemoptysis, and hemorrhage on X-ray. The X-ray can have a fairly typical sort of butterfly type pattern to it. It can also just look like an area of opacity similar to a pulmonary contusion or a pneumonia, but in the setting of trauma. There may not be other significant signs of external trauma. And as I said, this can be delayed, and we'll often have a picture of ARDS and respiratory compromise. In general, the care is symptomatic and supportive with oxygen and observation. Somebody who, while we said this can be delayed up to 48 hours, somebody who was potentially exposed to a force like this with a normal chest x-ray, normal vital signs, watched for 4 to 6 hours, as long as all that stays normal, can likely be discharged with good return precautions. And here's just sort of a picture showing sort of the opacity associated with a pulmonary contusion. Tympanic membrane rupture, quite common. Intact tympanic membranes are, because of the threshold to rupture that in the lower PSI. If you have intact membranes, there's probably a lower probability for serious blast injury, but it absolutely doesn't rule it out. Very common symptoms with that: atalgia, ear pain, vertigo, bleeding, typically supportive care, and just monitoring for any further signs of infection. Other injuries can include arterial air embolus, common cause of death. Concussion and TBI are one of the most significant GI injuries that can be missed. And then, of course, with patients flying and debris flying, there can be musculoskeletal injuries. So in summary, most common injury from incendiaries, or these essentially fire-starting substances, burns, typical burn care. Most common injury from explosives, primary to quaternary, blast lung and tympanic membrane rupture being some of the more common, but TBI is, in reality, is probably more common than some of the others. Always consider decontamination, whether this is in the field, but before contaminating other rescuers, ambulances, emergency departments, hospitals have to be decontaminated, and part of that is trying to figure out what substance is involved. Events will unfold prior to complete information, and trauma care is typically fairly standard, but trumps burn. I want to thank everyone for coming to this series and listening and learning. Thank you to Dr. Steve Cantrell and Dr. Peter Pons for their assistance with this presentation. They also developed the original Be Nice training course, and Dr. Pons addresses this topic specifically in a longer and much more comprehensive coverage of the topic. He is quite experienced in this field, so I would encourage anyone who wants to dive a little bit more deeply into this to check out the resources on the Mountain Plains site. And thank you very much.